short overview about the past treatments and outcomes of patients with brain metastasis. And then I will focus on systemic therapies and whether they are the future for patients with brain metastasis. And I think first you need to ask yourself some questions before you start systemic therapy. Then I will focus on immunotherapy and targeted therapies. So if you look at the past, the survival of patients with brain metastasis was in general quite poor. If you look at the disease-specific graded prognostic assessment scoring criteria, which consist of age, performance status, the presence of extracranial metastasis, and the number of brain metastasis, then you will see that most of the patients will have a score of below 3, and they will have a median overall survival of only 3 to 6 months. These are all patients treated with radiotherapy from the 1980s to 2007, so quite old data. If you look at the efficacy of chemotherapy, so if you look at the median overall survival of patients treated with upfront whole brain radiotherapy or upfront chemotherapy, then you can see that it doesn't matter for the overall survival with which you start, but the median overall survival is less than half a year. But as you know, immunotherapy and targeted therapies really improve the outcome of patients. And you can also see it already reflected in the molecular graded prognostic assessment, which included patients from 2006 to 2014, also treated with radiotherapy. And if you look at the adenocarcinoma patients and EGFR and ALK were incorporated in this, then you see that the patients with a higher molecular GPA score can achieve an overall survival of more than 2 or even 4 years. If you then look at what's in the current guidelines, I summarized the EANO-ESMO and the ESCO-ESTRO guidelines. So the ESMO states if you have a patient with no actionable oncogenic driver and asymptomatic or oligosymptomatic brain metastasis, then you can either start with upfront immunotherapy if you have a high PD-L1, or with chemoimmunotherapy if you have a PD-L1 that's below 50. And if you have patients with an actionable oncogenic driver and asymptomatic or oligosymptomatic brain mets, then you can start with, I was summarizing the guidelines, and I think the ESCO is a little bit more cautious than the ESMO guideline. So for EGFR and ALK positive patients and asymptomatic CNS metastasis, they also state that you can give a TKI. But if you have no oncogenic driver, then they say, well, we don't have a real consensus, but pembro chemo is an option. And they don't mention pembro alone for high PD-L1. And I think you also need to understand that the evidence is quite low for most of these recommendations. We performed a systematic review, so we checked the eligibility criteria for patients with brain mets in phase 2 and 3 trials. We included over 250 trials, and if you look at the figure, then you can see that especially for immunotherapy trials, patients had to be treated and stable. And I think before you start systemic therapy, you need to think of what you want to achieve with your treatment. So I think you want to have local control and freedom from new metastasis. So in the end, you have intracranial control, you want quality of life, but you also need to take into account the extracranial control. So whether you need to start systemic treatment soon. And in the end, you want to improve the survival while maintaining quality of life. So you need to think of, does the systemic therapy penetrate the blood-brain barrier? The risk of neurological deterioration if you don't have a response of your systemic therapy, but also the toxicity if you start with upfront radiotherapy, and indeed the need for immediate systemic therapy. So first, I will focus on immunotherapy results. And as also was discussed by Professor Peters, brain mets have a different tumor microenvironment. We know that immune cells are present in the brain. We also know that brain mets often have a high TMB, but there is a discordance between tumor PD-L1 expression in the brain and extracranial metastasis. And important, the T-cell clonality in the brain is less, and the brain immune environment is more immune ignorant. And there are data mainly derived from monoimmunotherapy or chemoimmunotherapy in patients with treated brain metastasis. And you can see if you compare it with chemotherapy, then patients with and without brain metastasis do derive benefit. But as I stated, most trials excluded untreated or active brain metastasis. And only in the Keynote 189, patients with untreated brain metastasis were allowed, but this subgroup was not separately presented. It's also interesting that in the Empower 150, there seems to be a protective effect of bevacizumab for the development of brain metastasis. And we have one immunotherapy brain met specific trial enrolling patients with non-small cell lung cancer. The majority of these patients were PD-L1 positive. They were very selected. They had asymptomatic brain metastasis. So these patients were asymptomatic, didn't have steroids. And if you can see here that the response rate in the brain mirrored the extracranial response rate, was around 30%, but dissociated responses were noted, and you need to be aware of this. And if you look at the real-life data, I think these real-life data quite mirror the data of the phase 2 trial. And especially the patients that are PD-L1 high positive can achieve quite impressive response rates and median overall survival. I think for those with a low PD-L1, monotherapy, immunotherapy is not the way to go. We also have data for combination immunotherapy with or without chemotherapy for treated brain metastasis. So the first, the CheckMate 9LA, also discussed by Professor Peters. Brain met subgroup was quite substantial, but all patients had treated brain metastasis. And the intracranial PFS was much longer for the chemo immuno arm. And also the percentage of patients with new brain metastasis was lower, and the time to new brain metastasis was longer. If you look at the CheckMate 227, I think more or less the same data, at least for the overall survival, but the intracranial PFS was similar. And the patients in the immunotherapy arm had less brain metastasis, but the time to new brain metastasis was shorter. And with these regimens in treated brain metastasis, you can achieve a 2-year overall survival of 35 to 43%. Now we also have phase 2 data for untreated brain metastasis with chemoimmunotherapy, and that's the atezo brain. Chemoimmunotherapy upfront for patients with asymptomatic brain metastasis without an oncogenic driver, and baseline steroids were allowed, and 43% of patients used baseline steroids. If you then look at the systemic PFS, then a median PFS was almost 9 months, with a 1.5-year PFS rate of 25%, and important, no new safety signals. And again, a 10% discordant response rate, so you need to follow up these patients also with brain imaging. Intracranial PFS was a little bit lower, 7 months, and intracranial PFS rate was only 10%, but the 2-year OS rate was again around 35%. So it is something that's interesting to start upfront with chemoimmuno, but follow the brain. And there are quite a lot of trials ongoing with systemic therapy for untreated non-small cell brain metastasis. The most are chemoimmuno or chemoimmuno. And as already discussed by Professor Peters, I think maybe the chemoimmuno regimens are the most interesting because the brain tumor microenvironment is different from the extracranial tumor microenvironment. But I think that still doesn't answer the question what's better, whether you need to start with upfront radiotherapy followed by chemoimmunotherapy, or upfront chemoimmunotherapy and then radiotherapy upon progression. But both ETOP and ERTC have protocols in development. If we then move on to the targeted therapies, it's important I cannot discuss all TKIs because there is just too much data. But if you then look at the oncogenic drivers we have, then you see for baseline incidence, it's around 20 to 40%. It depends on the trial you look at and whether there was baseline brain screening. And I think the cumulative brain mets incidence is really influenced by the TKI you use. If you use a first generation TKI like crizotinib, the blood-brain barrier is really a limiting step. And we don't know whether the biology in the brain mets is really different from the extracranial disease. So it could also influence the brain metastasis incidence. If we then look at osimertinib in the FLAURA trial, more than 100 patients with brain metastasis were enrolled. And the CNS response rate was 2/3 for osimertinib versus less than 50% for first generation TKI. Also, the CNS PFS was longer for osimertinib, and less patients developed new brain metastasis. If you then look at the T790M patients, then again, osimertinib had a quite impressive response rate of around 2/3, with a mainly impressive median progression-free survival for EGFR exon 19 deletions. If we then go on to the ALK-positive patients, you can see for alectinib, brigatinib, lorlatinib, and ensartinib, similar data. I couldn't put the same figures for all these different TKIs in, but PFS is longer, intracranial progression-free survival is longer, intracranial response is longer, and if OS data is available, it's also longer for the next generation TKI. Then a short summary of other oncogenic drivers. We know that's already been discussed that there are different TKIs or small molecules available. If available, except for crizotinib and ceritinib, the intracranial responses are quite good, but you need to be aware these are very low numbers of patients, and it was not really well taken into account whether these patients had previous radiotherapy or not. And if you can achieve a response with these drugs, if available, the intracranial response is quite long. Also, I think an important discussion in these oncogenic drivers is whether we can start with upfront TKI or with radiotherapy. Retrospective series suggest that you can start with CNS penetrating TKI and only use radiotherapy if you have progression in the brain. But there are also some discrepant data, again, retrospective series showing that if you have oligometastasis in the brain, then maybe it's better than to start with upfront radiotherapy and then go on to the TKI. So for the future, I think if you have local CNS progression, I think we need trials with TKI and concurrent radiotherapy to evaluate the safety and efficacy and also to prevent a systemic disease flare. We need to evaluate the CNS resistance mechanisms, and I think liquid biopsies of the CSF are very promising. We need to evaluate TKI dose escalation strategies. There is a limited benefit in small prospective series, but we don't know what the plasma levels of these patients were. I think combinations with chemotherapy and anti-angiogenesis are interesting. And for the future, I think the FDA had quite interesting recommendations. We need to document the prior CNS therapies because it really hampers your trial comparisons. We need to stratify for prior therapy. We really need to assess regularly with brain MRI, and we need to follow up these patients. And we need to apply accepted CNS response criteria and define appropriate endpoints. And this guidance document is necessary, as in our systematic review, we showed that these recommendations are not in use yet. So my conclusions, I think untreated brain metastases are often excluded from clinical trials, and I think that's not justified. Immunotherapy combinations are effective in subgroups of patients, but you need to be aware that the associated responses are present, and we need to better select patients, and we need to understand the brain tumor microenvironment. And again, I didn't show you the data, but radiotherapy and immunotherapy research is really necessary. We know that CNS penetrating TKI are very effective, and research is needed regarding TKI combined with chemo or anti-angiogenesis and the sequence of radiotherapy and TKI. And we also need to design our trials better and incorporate RANO and FDA guidance. And as these patients live long, we need long-term follow-up. So thank you.